Alrighty, thanks for bearing with us through what I think so far has been an amazing program with some fantastic presenters, and I just think the opportunities in this field are very exciting. So as Dan mentioned, I'm here to talk about stepping out of the shade, shade being the program that we've developed in Newcastle that addresses comorbid depression and alcohol and other drug use problems. So why are we particularly focused on drug and alcohol use and mental health comorbidity? And I'm sure it's not telling you anything when we say that is the rule rather than the exception out there in the real world outside of our little research clinics. And so in Newcastle, and certainly working with David over the years, we've really been committed to having a look at how traditional treatments for mental health problems and for drug and alcohol use problems might be applied and might need to be tailored or changed as they to address comorbid conditions. And we're interested in this because people with comorbidity experience increased burden of disease and disability than people experiencing single conditions on their own. And particularly for things like depression and alcohol and other drug use comorbidity, there's such a consistent association between things like suicide, depression and alcohol use problems. And the two really present a person with many more challenges and complexities than dealing with either disorder on their own. As I said, we've been trying over many years to develop what we hope is a clear treatment model for the management of comorbid mental health and drug and alcohol problems, with David well and truly integrated within that program. But still to this day, we don't have a clear idea of what works best. And certainly what we do know is that people with comorbidity have trouble accessing treatment. And so if we want to do anything about this situation, we've come to the realisation that we can develop as many effective treatments in the context of our research trials as we'd like, but if we want to have any hope of changing this situation outside of that, then we need to be thinking about how we can disseminate these treatments effectively and somewhat creatively. And that's fuelled by stats, which I'm sure you've heard so many times now, that the majority of people with mental health problems don't actually or can't access treatment for their conditions. And when you think about some conditions like depression and substance use comorbidity, these problems are really borne out more so. Again, we've spoken already this morning about some of the challenges we experience within our current healthcare system. So certainly Australia, compared to even other developed countries, has a lot of advantages within our healthcare system, but a lot of challenges as well. And they mainly come down to the resources that are available to deal with an increasing demand for service. So whether that be physical resources, technology resources, financial resources, or human resources, we're limited in the capacity that we can respond to the increase of mental health and drug and alcohol use problems that we're all noticing worldwide. And so this can often lead to a high level of frustration, not just with practitioners working within these services, but also with clients themselves who are struggling with what are quite severe conditions and are often left unsupported, and particularly with things like depression and substance use comorbidity, unable to work out whether it's the mental health or the drug and alcohol service that they need to engage with. And so that's why eHealth is really an exciting opportunity for us poor old comorbidity researchers who are looking for answers to these sorts of questions. So when I say eHealth, I mean it's this rapidly expanding field of health information and communication technology. And certainly Australia was one of the first nations to recognise the importance of eHealth approaches. And back in the 1990s, really was the leader somewhat internationally in integrating some of these practices into clinical healthcare services. And there's certainly widespread recognition, I think, by the roll-up today that these eHealth approaches really do have a lot of potential to be integrated within our existing healthcare services and practices for some benefit. And along with this, out there in the real world as well, has been this increasing acceptance that the individuals themselves can take some responsibility for managing and negotiating their own healthcare and for being active participants in their own healthcare needs. And certainly this opens the door for the use of eHealth in helping address the problems with which they present. Again, we've covered these sorts of issues already, but the eHealth, the internet, computers offer a range of accessibility opportunities that we're unable to provide within the limits of our current service and clinical practices. There may be reductions in stigma associated with accessing treatment online as opposed to, presenting to a scary psychologist for some kind of treatment. And again, this tailoring and the ability for clients to work at their own pace and tailor the information as to what's relevant to them at a particular point in time, I think is a real benefit which we haven't explored fully. And again, in terms of circumventing some of the challenges of treatment access, particularly for comorbidity, eHealth certainly holds a lot of promise. And again, we know that the use of the internet, even in home, especially at home, is increasing. More people than not have access to the internet in their home. And we get to replicate this in Australia, but in Canada at least, what we're also seeing is that people with drug and alcohol use problems are also just as likely to have access to the internet, whether it be at home or via their phones, than people who aren't using alcohol or other drugs. So there is real potential there. To date, there have been a lot of randomised controlled trials and other kinds of trials that have looked at how well eHealth interventions can address a range of disorders. So I've just listed the main ones up there. And for us, this was a really good starting point in how we might then address this important issue of comorbidity. And that brings me to the SHADE project, which is my first baby, apart from this baby that's coming, hopefully not today, that is really one of the first to tackle or to bring eHealth approaches to the issue of comorbidity, and specifically depression and substance use comorbidity. So I'll talk a little bit about SHADE now. It was developed in the Hunter and run in collaboration with the Centre for Rural and Remote Mental Health, also in New South Wales, because rural and remote populations are often stand to benefit a lot from these types of approaches. And what we wanted to do with SHADE was to really target both depression and a person's substance use problem and help them to explore the links between the two conditions, and really use cognitive behaviour therapy and motivational intervention type approaches that we know work for the conditions occurring in isolation and we know work in face-to-face delivered format. For the first time, again, what we wanted to do in this trial was actually pit our computerised SHADE treatment program against a whiz-bang psychologist-delivered CBT motivational interviewing fabulous program with all the bells and whistles, I'll say, and then compared that again with what we call person-centred therapy, so a supportive counselling intervention that really didn't offer any particular strategies but allowed a person to come in and speak about whatever they felt like speaking about at that point in time. And the therapist offered that warm, unconditional, positive regard, those non-specific elements of therapy that are also very, very important in engaging and we think also in treatment response. So each of the 3 treatments that we compared against each other went for a 10 weeks in duration. And I should also say that in the context of this trial, because we're a bit scared and somewhat conservative in little old Newcastle, we didn't just want to run a computerised treatment intervention without any check or balance integrated within it. So we offered people a 10 to 15 minute generic kind of check-in session at the conclusion of each of their computerised treatment sessions. We monitored their mood, we did a suicide at risk assessment, and we checked for their understanding and compliance with the types of things that they'd undertaken during the computerised treatment session. And we've just completed our 3-year follow-up on this particular trial. I'm not going to talk to you about a whole lot of stats, but when you've worked for 10 years on a project, I'm compelled to show graphs of 3-year follow-up over time, so I'll just do that quickly now. So this is for the domain of depression, so depressive symptoms, and we measured that at baseline through the follow-up period for through to 3 years. And we have our 3 different treatment programs displayed up there. And the red one is the clinician-assisted SHADE computer treatment condition. So with depression, we had significant reductions in the people's self-reported levels of depression across the study period, which was the greatest between baseline and the post-treatment assessment, but that these reductions were maintained through to the 3-year follow-up period and were of the order of around 50% reduction in symptoms relative to a person's baseline assessment. And there were no significant differences between our 3 treatment groups. So our computerised treatment intervention was doing just as well as the whiz-bang fabulous clinical psychologist-delivered treatment intervention. In alcohol, for alcohol use, this shows the group who met criteria for hazardous alcohol use at entry to our study. So people who are consuming well in excess of the recommended guidelines for drinking in this country. So again, participants generally reduced their alcohol use over the course of the study. But again, you can see a little bit of a relapse for those in the supportive counselling intervention over the longer term. For our clinician-assisted computer participants, those in the SHADE treatment program, they reported a 62% reduction in their drinks consumed per day relative to baseline. For those in the therapist whiz-bang treatment group, this was 44% reduction. And for those in the supportive counselling intervention, they had that relapse of around 20% at 36 months. So there was a slight trend towards the SHADE computerised treatment participants performing slightly better in response to the computerised treatment intervention than were the face-to-face delivered clients. For the characteristic of binge drinking, so the frequency with which our participants reported engaging in binge drinking over the course of our study, again we can see the computer treatment condition, although it's clinician assisted, and our whiz-bang clin-psych treatment are keeping pace with each other in terms of reducing the frequency of binge drinking over the course of the study. And our supportive counselling intervention really didn't do much to make inroads into binge drinking at all, which is interesting. So it might seem that introducing some clear strategies to work on binge drinking rather than just talking about those sorts of things might be more effective. And finally, for cannabis use, again, for people who met hazardous use criteria for cannabis, so they were using regularly, at least weekly, but it was most often daily at entry to the study. Again, our clinician-assisted computer participants reported about a 2/3 reduction in their pot use per day at 3 years relative to baseline. This was a little in addition to, a little in excess of those in the therapist delivered group who reported a 44% reduction, and then the PCT, the supportive counselling condition, reported around a 30% reduction in their pot use. But there was an interesting pattern of kind of relapse just for that supportive counselling condition, and also for the clinician-assisted SHADE condition at around 6 months, which we're not sure what it's about, but might indicate a pivotal point for some additional support perhaps to be supplied around that time. So in terms of SHADE as applied to people with the complexities and the seriousness of comorbid depression and alcohol and other drug use, we're really encouraged by these results and thought that this presented a bit of evidence to suggest that the sorts of approaches that have been applied to people with single disorders could also be applied with success to people with comorbid disorders. And you might say, oh, that's obvious, but for researchers that's pretty special. And so really one of the key challenges that faces us with SHADE, and I guess with the sector more broadly, is that there are still some barriers to the uptake of these types of approaches in clinical practice. So it's not necessarily that the evidence isn't there to support their use, particularly over or in concert with therapist-delivered and supported packages. But certainly things like access to technology remains a massive issue in our services, as we've already touched on today. There's also somewhat of a reluctance of healthcare providers to integrate these sorts of approaches into their clinical practice. And I think that scepticism is really important in this particular area. Just because we have the technology, it doesn't mean that we should use it. So certainly randomised control trial evidence is important, but so is evidence about real-world service-based dissemination. So how does this work when you take it out of the lab, out of people who are fully invested in this technology and want it to work, and put it out there in the real world? And that's certainly where efforts now need to be focused in a nice, controlled and well-designed way. There's also seems to be a lack of understanding about the community generally, and maybe clinicians in particular, about how this type of treatment might actually look and feel and work. And certainly when David's mentioned the Commonwealth-funded consultation that he led on existing drug and alcohol websites. And when we did our focus groups and talked to people about, would you use the internet for treatment for a drug and alcohol use problem, people most often responded with confusion, like, what the hell do you mean? Do you mean like Messenger or online AA or whatever? And they didn't have a clear concept of the sorts of things that they would be engaging in. And so, I mean, that's not uncommon, I guess, for traditional psychotherapies and traditional counselling. People have this, it's almost like a black box of what's it like and what are we going to do? And certainly that seems to be applied to this field as well. And we've got a real challenge and a real impetus to try to destigmatise or open up the black box, step out of the shade, and really educate people about the benefits of this type of approach, what it feels like, what it looks like, and then to make it more accessible in the long run. And so in terms of shade specifically and eHealth more generally, I think these types of interventions can really increase adherence to best practice or to evidence-based treatment, and also can indeed help empower clients to manage better on their own. And to become active agents in their own healthcare. And certainly we've been able to show that you can apply it to this sort of technology to people with complex and severe types of conditions. And so the use of these types of initiatives may be more of a question of preference, so provider preference, client preference, and potentially cost as well, as opposed to whether or not we've got the evidence that they work, because we're seeing too. So thank you very much for coming along and supporting this kind of work, and welcome any sort of questions at the end. Thank you.